Okay, our presenter that we have is Dr. David Andrews. Next, he is with IMVAX. So when I say IMVAX, it doesn't always sound right. It's IMVAX. And he is going to talk today about a phase 2B study of IGV 001 in newly diagnosed GBM. He is the Chief Medical Officer and founder of IMVAX, and he has over 30 years of experience as an academic brain tumor neurosurgeon, completing his residency at New York Presbyterian Cornell and a fellowship at Memorial Sloan Kettering Cancer Center, both in New York. As a junior attending neurosurgeon, he received a prestigious NIH Physician Scientist Award to study brain tumors. And he has devoted his career to find better treatments for GBM, for glioblastoma. He currently serves at St. Thomas Jefferson University Hospital as professor and vice chair of clinical services, Department of Neurological Surgery, and chief of the Division of Neuro-Oncology. Dr. Andrews, are you here?
I am, and it's a pleasure to be here, Delanne and Susan both.
Thank you.
And thank you very much for having me. Fantastic. Okay, let's roll. So I'm, as you pointed out, I'm an academic neurosurgeon. I founded this company in 2015, and we got FDA approval to go forward in actually December of this past year. So wow. We are open and accruing patients. So let's go to the next slide. So what is IGV-001? It is actually a personalized cell-based therapy. When it's a patient's own tumor cell, that's called an autologous treatment, taking your own cells and then actually using them as a source of an immune treatment. We have what is called GoldSpire, which is our immuno-oncology platform for not just glioblastoma, but other solid tumors. But really our major focus, since I'm a neurosurgeon, is glioblastoma, and we'll get into the newly diagnosed glioblastoma trial. So it's an investigational treatment. Again, as I just mentioned, it's FDA approved. By launching a phase 2B trial, the idea is that with success, we'll go on to a phase 3, and actually with regulatory approval, then it will be a new standard of care. So that's the trajectory that we're aspiring to here. I'll finish near the end of the talk with a phase 1 study that actually fueled this phase 2B study. And we'll go into that in a second. Next slide. So how does this work? It's actually great that Jay McCracken was on. We're actually involved with Piedmont actually as well. But the upfront treatment of glioblastoma is sort of a frontier. Most of the work that's being done is with recurrent disease, because there's really no standard of care when these tumors recur. So what happens here is the cadence is one in which, sort of like gamma tile, you're actually intervening at the inception of treatment. So craniotomy is performed. The difference being that instead of tissue going to pathology and the rest of it being discarded, all of that tissue is actually collected, sent to our cell production facility in Philadelphia, and then sent back to the site, where in fact is then implanted in the abdomen. Now, how did I come up with this idea of putting something in the abdomen, a malignant brain tumor? Well, certainly abdominal incisions we make all the time as neurosurgeons for a different procedure called a ventricular peritoneal shunt. From a immunologic standpoint, the belly button or the umbilicus is sort of the meridian for lymphatic drainage. Anything above the umbilicus goes north, anything below the umbilicus goes south. So we implant these chambers. These are small biodiffusion chambers about the size of a dime, into which, when the tumor comes out, we process the cells into single cell suspensions at the cell facility. We put them in these chambers, and we actually then treat them for a period of time with actually another agent called IMV001, which is a molecule that works against a protein that actually we think maintains the malignant phenotype in GBM and just about every other solid tumor. So we treat the cells with IMV001, we encapsulate them in this chamber. We then spike the chamber with additional IMV001 so that actually excess IMV001 diffuses out of the chamber when implanted in the patient. So we have living cells going into the abdomen in these small chambers. We also radiate the chambers before we implant them. These are all FDA requirements. They didn't like the idea of redistributing a live cancer elsewhere in the body, even though it's a tumor that doesn't really survive very well outside the central nervous system. The chambers remain in the patient, so we make incisions in the abdomen during the closure of the craniotomy. Cell production process takes place, and 2 days later, next slide, we can go through this process. The cells come back and they're implanted. So when the biodiffusion chambers are in, what's diffusing out of these chambers, which actually have a very small exclusion limit. So cells are about 20 microns. So there's the pore size of these chambers is a half a micron. So dying cells, so we drive these cells to a cell death during the time in which they're implanted. And this is releasing the full antigen payload of that particular tumor in that particular patient. So just to be clear, 98% of solid tumors have mutations which are unique to that tumor and to that patient. So you can't use a single somatic mutation and hope that it has any impact on the course of that disease and that tumor. So by implanting these chambers, again, it's below the umbilicus. Whatever is diffusing out of those chambers is actually activating the innate immune system, next slide, which then it trickles down to the lymph nodes in the groin, where in fact the adaptive immune system then takes over. So this is the protocol, and if you have interest, you just have to go to clinicaltrials.gov. You don't need to know the clinical trials gov identifier. You can just actually punch in IGV001 and you'll come up with this trial. And all the details of that trial will be there. Next slide. So how can a study, what can they expect? We talked about the craniotomy to remove the tumor. So the phase 2 trial, we have enough confidence that the impact of this is going to lead to not only better progression-free survival, but overall survival. But we have to do this with a double-blinded prospective randomized trial, because unfortunately, since this TROOP trial was initiated almost 20 years ago, there's been no progress, even with very more recent generation immunotherapy treatments. So the only way to convince the FDA that this is really truly having an impact is to randomize patients between implanting chambers that are fully formulated for this treatment in 2/3 of patients, while 1/3 get a placebo, which is essentially the chamber with nothing in it. When patients are in front of this, they may say, well, I don't want to be in a placebo arm. And we can certainly understand that. But again, this is double-blinded. The likelihood is you're going to get the treatment. But if you're not getting the treatment, you're actually by being enrolled in a trial, and particularly when this is called an add-on placebo, you're getting standard of care, and you're getting standard of care at a concierge level. You're getting much more attention. In fact, there's literature that supports the fact that if you're enrolled in a trial, your outcome is going to be better regardless. When you compare it to community treatment. So we think that there's actually, with FDA strong support for this is the way forward. So the cadence is, go to the next slide. The primary objective is to prevent progression of disease. So that's an early indicator. So that when the disease progresses, that's the median progression-free survival. That's the point at which there's recurrence, and then subsequent treatment could involve reoperation or a different route of chemotherapy or some means of controlling the tumor. And of course, overall survival is the overall objective. In our 1B trial, which I'll close with, there's a very high correlation between progression-free survival and overall survival. And of course, as with a 1B trial, safety is a very important objective as well. Next. This is a very busy slide, and I'm going to have you refer to actually the clinicaltrials.gov to get a better sense of the flow here, but essentially it's everything I've just mentioned. But this does go to you implant the chambers 2 days after the surgery itself, you explant the chambers 2 days later. So the entire process has taken place during one hospitalization, which is under standard of care, and a DRG. So it's before 6.2 days. So we're not extending hospital stay by DRG standards at all. So the entire treatment is done within that hospitalization. But the immune response is then actually going to persist thereafter. And that's where we get into the responses. Next slide. So I've already talked about the design of the study. Next slide. So we can kind of say there's sort of 5 periods then. So there's a screening period where we make sure that patients are eligible for the trial. The randomization takes place literally intraoperatively. So as neurosurgeons, we're in front of these patients and we're typically saying, we think this is what this is. But it's actually, we know what it is, but we just need now confirmation with the frozen section. So with that assurance, we actually have patients consent to this procedure before we actually get a diagnosis. But the vast majority of patients have this disease, and thus intraoperatively, based on the frozen section, if it's actually confirmed as malignant glioma, they're randomized to this trial. So the randomization period occurs the same day as craniotomy. 2 days later, we do the implant. The treatment period is thereafter. Under treatment, their initial follow-ups at 14 and 28 days, and then standard of care takes place at 6 weeks. Now, standard of care, which is adjuvant treatment, can be 2, 4, or 6 weeks later. Anything beyond 6 weeks is considered outside of that envelope of standard of care as practiced in the Stoop protocol. We found that 6 weeks, based on actually consortium meta-analysis, the RTOG, this is over 3,000 patients, that actually 6 weeks has some advantage over 2 to 4 weeks. So by pushing adjuvant treatment out to 6 weeks, it's allowing the adaptive immune system to actually take hold. Because I think, as Dr. McCracken said and others, radiation and chemotherapy will actually deplete the immune system. And if this is an immunotherapy, we're working against ourselves by moving the radiation and chemotherapy up to earlier points in time. Next. So what happens if patients are interested in enrolling? So we talk about the risks, the benefits. There is very little risk, we think, or any, to these abdominal incisions. So based on the 1B trial, which I'll go through in a second, there were no really adverse events with this 33 patient trial. So you go through an informed consent, we go through the screening period, and then off to surgery. And of course, participants can withdraw it with their consent to participate at any time in the study and for any reason. Next slide. So eligibility is based on what we see preoperatively, and that's obviously first, the MRI scan is the key piece. We need an MRI scan that shows a contrast enhancing lesion in the supratentorial region. So we can't treat lesions in the brainstem or the cerebellum, particularly the brainstem. We can't get enough tissue to actually initiate this trial. So we need a threshold level of tissue to make this product to reimplant in the patient. We go through other standard blood tests. I mean, these are actually inclusion criteria that are quite universal. Next. So it has to be newly diagnosed glioblastoma, ages 18 to 70. I mean, it tugs at my heart that we can't treat patients older than 70. And that's only because if we're trying to actually emulate standard of care as currently practiced. The Stoop protocol did not include patients older than 70. And really, to compare apples to apples, if we're trying to push to change standard of care, we have to compare that to what the current standard of care practice is. So we hope in the life cycle of this product that we can actually initiate a trial for patients older than 70, and that will be a future endeavor. Next slide. So exclusion criteria, again, this you can go to actually the clinicaltrials.gov website to get those details. Next. So this was the phase 1b study that we published 2 years ago. So this was a dose escalation of this product in actually cohorts of 8 patients each. So typically you escalated a treatment by escalating the dose of that drug. In this case, it's what's coming out of that chamber, which is unique to each patient. So we can't actually identify an API or an active pharmaceutical ingredient or a drug. So it was the number of chambers and the amount of time that chamber was in the patient. So we randomized 23 patients with either 10 chambers implanted for 24 hours, 10 chambers for 48 hours, 20 chambers for 24 hours, or 20 chambers for 48 hours. But what we found was that by the 23rd patient, the highest dose of 20 chambers for 48 hours, those patients were outperforming all the others, and also actually mounting immune responses that were actually durable and far greater than the other cohorts. So that's what we carried into the actual phase 2b study that we're actually open with now. So as mentioned, this was very well tolerated, no immune-related adverse events. Initially, based on the incisions we were making in the abdomen, we were trying to create more room for the chambers. We had some hemorrhages that we realized we could avoid by not going above or below the inscriptions, which are that's your 6-pack if you're really fit. So you just stay within 2 inscriptions, and none of that happens. And again, the paper, which is referenced here, published in just a little over 2 years ago, extended both progression-free survival and overall survival. Next slide. So again, this is about IMVAX. We are in Philadelphia. That's where the cell production process takes place. We've enrolled 5 patients so far, so it's just the beginning of our journey, but we have 25 sites actually on the East Coast and all the way south to Jacksonville and west to Madison, Wisconsin. So our website is www.imvax.com. For those interested, if you want to pursue this and you're in that envelope, it's essentially 1,000 miles from our production facility, then we can probably accommodate you. So I'll stop there. Next slide, I think that's the last slide. And open to any questions.
Thank you, Dr. Andrews. That is fascinating. Fascinating. I'm going to be quiet for a minute and let our audience ask you questions, and then I have a question for you. And I see a person clapping. I love it. Love it. Anyone have questions for Dr. Andrews? Well, first of all, I just would like to thank IMVAX and yourself for investing, real dollars, right, into research for newly diagnosed GBM patients, because like you said, it is an area that needs more investment into it. There needs to be more research. Exactly. So thank you for doing that. I appreciate you talking about something that we sometimes forget to talk to patients about, and that is when you are entered into a clinical trial and you are participating, there is a level of what we call concierge service. Can you talk about that again? Because that was really important. Also, the part where there is documentation about people who are enrolled in a clinical trial who receive concierge service. They do survive better, and they do better on that, whatever that treatment option is.
That's been documented. There's the recent publications as recently as last year. I mean, it's sort of intuitive, isn't it? It's you really get a lot of attention, and I think in a broader sense, I will say this as a general statement, and all of my colleagues who have been on this seminar today, these are and I'm looking at Ashley, and thankfully you didn't have a GBM. But the patients with malignant disease are probably the most gracious and courageous people I've ever dealt with in oncology. So I think when you look in a broader view, what we're doing is we're accelerating a treatment that by doing a placebo-controlled, double-blinded placebo-controlled trial, and with their participation, even if they recognize there's a third of a chance that they may only get a placebo, that if this is successful, I mean, it will have a much broader impact on the entire cohort of patients that have this disease.
Absolutely. Thank you. Thank you. We will put up your contact information again, and also for anyone who's interested in learning more about this clinical trial, and for those of you who do not like to go to clinicaltrials.gov, IMVAX has put together a website actually specifically for families and patients for this particular trial, and there's also an email right there in front of you that you can email. It's patients@imvax.com, where you can email your questions, et cetera, et cetera. And one of the things I noticed a few days ago, I was on clinicaltrials.gov, I was on this particular clinical trial, and you know, there are several sites that aren't recruiting yet, but there will be. But is it okay for me just to quickly run off the sites that are recruiting?
Sure.
It's so Tufts Medical Center, which is in Boston, Henry Ford Health System, that's part of the Detroit, Michigan area, Dartmouth Hitchcock Medical Center, New Hampshire, I'm not sure how to say this, Montefiore Medical Center, which is in the Bronx, Northwell Health at North Shore University Hospital, New York. Let's see, we've got Cornell is recruiting in New York. We have, Lenox Hill. I did a great talk there one time. They're recruiting. UC Health, Cincinnati, Ohio. The Ohio State University Wexner Medical Center is recruiting. Rhode Island Hospital is recruiting. West Virginia University, West Virginia, recruiting. That was 2 days ago when I pulled that report, but there's several more sites that are going to be coming on that are recruiting. So
yeah, Columbia is activated.
Okay.
Sloan Kettering is activated.
Really, really cool. And if anyone ever feels like they want to just email EBCI and ask, hey, is whatever we heard about today, is it recruiting where I'm at X? You know, we're happy to look that up for you, and of course provide information for you to put you in direct contact with that principal investigator or that site that is recruiting, that is as close to you, or of course, all of our presenters today provided really great information on how to get a hold of them. So that is amazing. Anyone else have a question for Dr. Andrews?
I'm going to jump in because people are being very, very courteous and putting in the chat. So why are patients with both sides of the brain involved with GBM not eligible? So those are called butterfly gliomas. We actually included them in the 1B trial. So one thing that I learned was we weren't cherry pickers, we took everybody. Butterfly gliomas, unfortunately, have a really very poor prognosis. And we actually found that in the phase 1B study. We actually did extend life in one patient, but they're generally, it's not even written, but no prospective randomized trial will include them. It's a very small subpopulation. So you're taking a high unmet need and trebling it when it becomes bihemispheric.
Thank you. Thank you very much.
You're very welcome.
Appreciate it. Thank you.